Well, good afternoon. I'm Dr. Matthew Stanford, and this is the presentation for the A.J. Weisberger Educational Series on Addiction. This is a fourth in our series of 5 this year. I'd like to thank Mark and Camille Weisberger for their generous donation that allows us to present this important series of educational programs on addiction and behavioral health issues. I have a very exciting speaker today. I'm excited to hear from Dr. Andrea Yatska is Assistant Research Professor in the McWilliams School of Biomedical Informatics at UT Health Houston. She is also the Associate Director of the Houston Emergency Opioid Engagement System, HEROES, a national clinical trial providing comprehensive treatment for individuals suffering from opioid use disorder. The program is a collaborative partnership with the Houston Fire Department, Houston Police Department, Houston Recovery Center, and Memorial Hermann Hospital. A certified alcohol and drug counselor and a licensed chemical dependency counselor, she has worked extensively with justice-involved individuals in state and county correctional facilities. She received her doctoral degree in criminal justice from Sam Houston State University, and her presentation today, Local Landscape Resources and Best Practices in Opioid Use Treatment. And we're very excited to have Dr. Yatska with us. So thank you for being with us.
All right, good afternoon. Thank you for having me. I'm very excited to be here, and thank you for the introduction and a little of my background. So this is, like he had said, the Local Landscape Resources and Best Practices in Opioid Use Treatment. And then just to kind of fill in some of the gaps of a little bit about me, I kind of bring a couple of different hats with me in all of the work that I do. I've not just been kind of in one field my whole career. I've done a couple of different things that unfortunately end up overlapping, especially when we're talking about substance use and substance use disorder, because that is definitely a health disease that covers a lot of different landscapes. So my background originally from the psychology, sociology realm of things, very interested in people and delinquency and deviant behavior and kind of what makes us tick a little bit. And then really started to get into criminology and criminal justice. So starting to put that hat on of trying to understand criminal behavior and what influences those types of things, as well as the entire kind of justice system and the different interplay between all of the kind of varying levels of the justice system. I do have behind the walls experience. I joke that I did my time behind the walls, and to me that was some of the most beneficial experience that I've ever gotten, because reading something out of a book or just looking at kind of stuff on a paper, and that is one level of knowledge in our field, but working directly in environments and in populations is very important to really understand all the inner workings. And I definitely would not trade the time that I got to work in Massachusetts Department of Correction, as well as one of the jails up there, who had a residential substance abuse style treatment behind the walls, which was really neat to be a part of. So while I started on the justice side, like I said, it became very obvious early on that substance use played a very big role, especially in that population. And that's really where I started to kind of delve into understanding the disease of addiction, understanding counseling, and all of the elements that go along with that. And like I said, I come from a couple of different angles. I've worked with juveniles and families. I've worked with youthful offenders. Vermont's got some really cool things where they treat youthful offenders kind of differently up until the age of 22. So they don't put them into the adult system for a lot of the charges and things up there. Even if they are over the age of 18, they try and keep them out of the traditional justice system and keep them in family courts and have some other supports in place to prevent a lengthy, criminal justice history. And now I work at UT Health Houston. Our flagship program is the HEROES program we are going to talk a little bit about today, but we have a variety of other projects that really encompass a lot of the substance use and mental health landscape throughout the state of Texas. So for anyone that is online live, I would love if you can just throw some things in the chat, just trying to get a gauge of, who is participating today. Arguably, we all come wearing different hats sometimes, right? So sometimes we're in direct patient care, in treatment. Sometimes we're in general health care. Sometimes we're justice involved. Sometimes we're just those other community providers, and we're going to talk about those other community providers today and some of the roles that they play. And some of it just may be that you're interested. You have kind of a personal interest. Maybe you yourself are in recovery. Maybe you have people around you in recovery, or this is just a topic that you want to learn and know more about. Again, for anyone who's live, I would love for you to put it in the meeting chat. If you're not live and you're watching this later, I do just want you to kind of take a minute and think about 3 words that come to mind when you hear the word addiction, and create a little space here just for you to kind of reflect on what those words might be. And it's very much, kind of that what comes to mind quickly, what's that word association, what pops in your brain. And when you have those 3 words, kind of thinking about what did come to mind. What were the 3 things that popped into your head when you hear addiction, or maybe when you hear opioid use disorder, substance use disorder? What is that pops into your head as the next thing and the next thing? And usually when we do this activity, it's very interesting to kind of see where people go with it. And a lot of times when we hear addiction, we hear opioid use disorder, the common responses that we get a lot are very much, fentanyl's the buzzword, right? So you're going to get fentanyl, you're going to get overdose, you're going to get trauma, you're going to get struggling, you're going to get a lot of these words that often pop into our brains first. And I think sometimes it's easier, right, to pull those negative things out because that's what we're talking about. That's what media is talking about. That's probably all the things that are going on in the places that we're working, of just, how tough and how bad addiction is and what's going on out there in our landscape. And I want to also encourage people, though, to think about the other side of things, right? So I get that, sometimes this hopeless, this struggling, this dark, this, very, kind of dank place of being in addiction, the struggle of what that is. But for all of us that are sitting here and presumably, on the provider side, on the helping side, on the ally side, keeping in mind that when we hear those things, like, let's also kind of retrain our brains to think about the positive things as well, right? Of like that there is hope, that people do recover, right? There's 23 million people who identify as being in recovery in our nation. That there are ways to get treatment, and there's ways to be supportive, and there's recovery oriented systems of care, and all of these types of things as well. And so kind of think about, like, what words did you jump right to when I asked you to think about, what are the 3 words that pop into your head? And then kind of assess and evaluate those and see where you're at, because it's real easy to get stuck in the dark part of addiction. And if we're not being mindful about all of the reasons that we're doing this work, what we hope to accomplish with this work, what we hope to, support and help our loved ones with, we want to make sure that we're not stuck on the dark side, that the other side, the light side, the hopeful side, the treatment side, like those types of things are very important as well. And so when we hear all those dark things, like, it's, avoiding getting into that like pity party of things of like, oh yeah, it's horrible and this and that. And like, yes, that's true. And unfortunately, we're going to talk a little bit about some of the struggles and barriers that are out there today. But then the hope is, right, at the end, we're also going to talk about good things and programs and resources and stuff that's available. So keeping that in mind in your day-to-day of, let's not get stuck into all the things that are bad, but let's get in the solution. Let's think about what good things can come if somebody is reaching out for help, and how do we meet them where they're at, and how do we create motivation to help people continue with the treatment and to continue to build their support networks and continue their recovery journeys. So just kind of the 2 sides of the same coin, right? Like, yes, and what are all the other things that give us hope and the reason to do the work that it is that we're doing? So with that, I like to talk in most of my presentations about language and stigma. Little, language background here. Stigma, the Greek root being to mark and brand someone, stigma, stigmata, things like that, all kind of come from this idea of that somebody is marked as different from other people. And I think it's really important when we talk about stigma, of understanding how powerful the words that we use about people really are and the impact that it has. Because the way that we all kind of collectively talk about it, if everyone's kind of accepted, like these are the language of how we approach things or how we discuss stories or how we, review statistics or things like that, like that language is going to frame how society absorbs it and gets that information, and therefore how they think about it. And so how they think about substance use and how they think about recovery. And so when we're putting something out there, like it's being absorbed by the masses, and we want to be very mindful of that. The other side is right, the language that we use about people who are at the heart of everything that we're talking about here is framing how individuals think about themselves and their ability to change. If somebody's telling them something over and over and over and over, whether or not that's true, like we start to kind of accept it and believe it over time. And so if somebody's telling you like you don't have any power and you don't have the ability to change and you're just an addict and you're just this and you're just that and you'll never be anything, like if we approach it that way, people eventually will start to believe what they hear over and over and over, because every time they try and go against that stereotype, they're met with resistance, or they're met with people who, kind of don't allow them to grow and, become more than just the disease that they may have. And so that self-labeling and the things that go on are also something that we need to be very mindful about, so that we don't inadvertently, cause harm, whether it's on a societal level or at an individual level of things. And so one of the things that I was taught early on in this, when I got into kind of the justice realm and the counseling realm, and I had some really good mentors early on, and it's the simplest thing, and it's something that I think is very important to keep in mind in everything that we're doing, is it's real easy to kind of default when somebody's different from us, when somebody doesn't think like we do, when somebody, is making choices that we don't agree with, or maybe we don't understand, right? That default kind of is like, what's wrong with you? Like, I just want to shake you. Like, what's wrong with you? And having this idea that there's something inherently wrong with that person because they're not like ourselves. They're not like me. They don't think like me. They don't approach the world like me. And I don't get it. And if I don't get it, it's real easy to just default into that. What's wrong with you? Like, that's not how you should be doing things. And the easiest way is to just kind of flip it and remind yourself, right? Like, well, we're all a product of our experiences, our influences, our families, our environments, our role models. Like, all of these things come together and they've created who we are. And so if we start thinking about it differently, about like what happened to you, that's why we're here. That's why maybe someone's struggling. That's what's journey has kind of led them to wherever it is that we start to interact with them. And so it's really important to kind of flip our own mindsets of like, there's not something wrong with you. Like, there's a reason you're where you're at. And now we can process that, right? Let's kind of understand the experience. Let's figure out what's brought somebody here. And then how do we help them move forward and get in the solution and enter recovery, or to change things that they don't feel are working for them anymore? Like, all of those things can be really easy for us to just change our mindset. There's not something wrong with you, because again, that's very stigmatizing. It's stuff's happened to you. So what's happened to you that brought you here? What's happened to you that you don't trust people? What's happened to you that maybe opioid pain medication has entered into your life, and now that's a big reason of why we're at where we might be at? Like, there's a lot of things going on. And so we want to challenge stigma. And the best way we can do it is starting with ourselves, right? And then educating and helping others to not be stigmatizing. But let's make sure we're changing our mindset into that what's happened to you mindset, because that explains why we're here. And it's not an excuse, and it's not like a cop out of like, oh, well, nothing is, there's no consequences because of what's happened. That's not what we're saying. It's very much a just mindfulness of what's happened to you that's got you to a place where you think and behave and make choices and decisions, or you're stuck in addiction or whatever these things. There's a reason we're here. And if we want to undo some of those negatives, we have to understand that that's the journey someone's on. And it's not that something's inherently wrong with people. So the overview for today, just to get into, a little bit of what we're going to do here, right? We know that opioid misuse rates are bad, right? Like they're worse. They were maybe starting to show a little promise, and then a global pandemic happened, and everything kind of fell apart, and we absolutely took a step backwards in a lot of strides of what it is to make treatment accessible, and how do we come together with different strategies, different players, different stakeholders, and kind of put it all together to be a little more effective. And so I want to talk a little bit today about the landscape of what's out there and some of the barriers that we're dealing with. And that maybe is kind of that dark side of the coin that we talked about earlier, because there are some very frustrating things about our landscape. But then ending it more with this emphasis of like, there is hope, there's services. I'm going to highlight the program that I work with, which is just one of many that are available in the greater Houston area. And then, kind of see where we go from here, right? Of like, it's okay if there's things that aren't working, there is some things that are available that are helpful. And then there's still some gaps though of where we can be better. And hopefully that's the mindset that you take away of like, how can we fill some of these gaps a little better? So some of the tough stuff, right? So this is all forward-facing data. Texas Health Data Dashboard has, they've gotten a lot better about tracking, I will say that, but it's not perfect yet. But we're getting a little more recent data that comes in and is available, because for the longest time it was like we were stuck with like 2018 data, and we're like, all right, it's 4 or 5 years. Like 2018 is a whole different landscape. So they've gotten better with trying to track and collect data and catch up. So we're getting there, but we're still kind of coming from a big deficit in Texas where we have not emphasized data. But there are a few things we do know. Some of the things that they've put out there and tried to gather info on is that unfortunately, 1 in 4 Texans has experienced an opioid overdose or knows someone who has. And this, keep in mind, is opioid overdose, right? So if we were going to talk about who's experienced opioid use and who's, in recovery or struggling in addiction, or knows someone who's in recovery or struggling with addiction, that number would be a lot higher, right? But even then, 25% of our state has dealt very closely and intimately with an opioid overdose, either personally or with a very close loved one. And so I think we're definitely in a realm where it's impacting more and more people, because the numbers are unfortunately going in the wrong direction, right? But all the more reason that there's so much importance about what we're talking about, because we are being impacted on a regular basis. And it's important to kind of understand also, right, that you're not alone. If you are dealing with this, or you have loved ones that are dealing with this, like, it's not an isolated thing. And there's people who get it, and people who understand, and people who want to help figure it out together. So some of the data from out there, this is the most recent data they have up until 2022. So pulled directly just as screenshots from the website there. Texas trends, right? You'll see the opioids and any drugs obviously kind of have the same trajectory. Of course, there's more counts on the any drug side, just because it's a more wider net that's being cast. But we were, moving along for a little bit, and then we had a huge spike in the last 5 years. And so we are very much in crisis in our state. Whether you're looking at opioids or you're looking at any drug in the landscape, the number of deaths are very concerning, right? It has gone steeply up in the last few years, which means that there's even more urgency in trying to make sure that we can stop this from continuing to increase. And the hope, of course, is to not just plateau it, but to decrease it over time. So this is not the norm that we have to deal with on a day-to-day in our state. What's also very frustrating is when you start looking at ages. This is one of those where, like, the pink line here, this 18 to 44, like, that's, should be our prime, right? We're young, we're healthy, we're active, we're, doing things, we're, kickstarting whatever our lives are going to be, whatever our careers or fields or, our values. Like, this should be a time of excitement and growth. And unfortunately, we're seeing that 18 to 44, these prime years is really the amount of people like, or the age range of people that are getting hit the hardest by this. And so it also gives us some insight into, again, that landscape of we're hitting kind of the heart of, you know, who we are in our generations and what's coming next. And 18 to 44 is a really tough range to just accept that, like, oh, okay, yep, this is where things are the highest. Like, I feel like this is the prime opportunity for us to get in there and prevent these trajectories from being the way that they are, especially in this age group, because there's just so much potential still in that 18 to 44 range. And if you know anything about kind of the history and background of, you know, substances and tracking and things like that, it wasn't that long ago, back in the 60s in New York, before medication treatments really kind of hit the ground, we were seeing this same trend of, you know, like 18 to 35, it was, you know, the leading cause of death in that population. And there wasn't any hope. And there was a lot of struggles that was happening. The criminal justice systems were overwhelmed and just overcrowded, and there was no options at the time. And thankfully, we now have options. That's, you know, when methadone clinics rolled out, because we found the impact of those things. We've had a lot of other things enter the landscape since then when it comes to medication-based treatments, to other types of treatment and funding and support for this population. And so it's frustrating to see kind of history repeating itself a bit, especially in that young age range, that we've been here before. But the good news is maybe we've learned some things that can help us get out a little quicker this time and not just accept that this is the new norm that we're in. So just some local numbers as well. We get a lot of our numbers from City of Houston and the medical examiners to keep track of what's going on out there. So there's a sliver of good news here, in a sense that, you know, pre-pandemic, right? Like pandemic levels, everything got worse. Generally speaking, you'll see that 2021 was a real tough year, kind of across the board. That kind of first year post new world of pandemic and what was going on out there. But we are seeing a little bit of a plateau, and I don't want to get ahead of ourselves or get excited. But maybe some of the changes and some of the things that we've started to learn about different ways to create access to care and different ways to identify people who might need treatment and increase that accessibility. Maybe we are starting to chip away a little bit about that. So definitely more to come and to keep an eye on things, but you know, it definitely got worse. And the hope is that maybe we can keep this going and continue to implement the strategies that we found to be, you know, a little impactful in the landscape that we're working in. Caveat about statistics, right? Statistics only scratch the surface. Everything's undercounted, whether it's, you know, drug-related statistics, whether it's criminal behavior, you know, we're only capturing those that kind of end up on official counts, whether it's, you know, anything that you want to measure, it's going to be undercounted. University of Virginia did a big old study across states and was trying to kind of figure out what's the landscape that our official statistics show and what's the landscape that's really out there. And they've conservatively estimated that it's probably up to 35% higher than what our statistics show. And the biggest barrier there is kind of how opioid related deaths are tracked and counted and what that looks like. And we'll talk a little more about that, but take statistics with a grain of salt. And I say that coming with my research hat and with the landscape that I work in. Everything is data driven and, you know, capturing data, but data is not perfect. And anyone who's boots on the ground in this field knows that it's probably rougher than the data lets on, because we are seeing it. And so, you know, just the numbers, give them a certain amount of weight, but don't give them all the weight, because we know that there's more going on that don't get formally captured by statistics. The biggest barrier in Texas is our medical death investigation systems. So there's kind of three systems that different states have that they've chosen to roll out. There's the coroner system that some states are using, where somebody's elected, usually serves in a single county. There's some requirement variations across the states. You don't usually have to be a physician or have medical training, but there is usually some level of training if you take that role that you're going to have to learn. And they're usually supported with pathologists to help when it comes to the autopsy side or determining cause of death. Then there's the stronger system, which is your medical examiner system. They're appointed officials, but they're usually physicians or forensic pathologists. So they're trained in this realm. So they bring a lot more of that knowledge and education to the role that they're having. And then you can kind of serve differently depending on the state, whether it's county, regional, or state level. And then there's this lovely catch-all of just other county official systems. And this is what is probably the most frustrating about how medical death investigations are carried out and captured, because they're utilizing county officials other than a coroner or medical examiner. A lot of times, people who are just in, other types of roles in the government in that area. So justices of the peace, county attorneys, maybe sheriff coroners, other law enforcement may play this role. And so this is kind of the least healthcare trained, educated, and backed realm. And it's kind of using other roles to capture this information. And at this point, it might not be shocking to hear that Texas, unfortunately, on here, the green are the states that practice, for the most part, an other county official process of what we're doing here. So we do have, I believe, a total of 14 medical examiners across our state that have, a couple of regional areas where they are playing a role in, but keep in mind, we have 254 counties in Texas. 14 medical examiners for a state our size and with our population is absolutely being underserved. And that means that a lot of death certificates are being determined by people who are not medically trained or have any of that background. And so that plays a huge role into us not having great data and really understanding what's going on in our landscape. And of course, we're not alone, right? There's other states that, track and look at things differently, but we absolutely are coming from a deficit of really knowing what's going on in our backyard. So what are some of the things we do know? So we work closely over here with UT Health. We work with the Houston Fire Department and EMS, and we're looking at overdose calls over the time period of, and I realize this slide is not great. Let me go on to the next one here. Yeah, this one has the dates at the bottom here. So generally speaking, we track overdose calls. We've been tracking them since 2015, and there's kind of a method of criteria, right? Because sometimes naloxone is deployed very liberally with EMS, because if they come across someone who's non-responsive, their first attempt is to deliver naloxone, see if you get an opioid reversal. If you do, then you know what it is you're treating. And then if you get a non-response, then they move on and they try a whole host of other things to try and determine what's going on. So we have tiered out data that actually indicates that there was a positive response to naloxone, which indicates that opioids in some fashion were present. And we're able to categorize those as overdose calls. And so you'll see, again, this trend of we've always had calls like this. And then around 2020 and 2021, we had a huge spike in calls that were coming through that met that criteria. And we've settled a little bit, but we've never gone back to pre-pandemic status, which is really, really frustrating. So we still have a lot of work to do, but at least now we're able to capture a little more of what is happening, at least in the greater Houston area, of what's happening with overdose calls. So just kind of in another format, right? If you look at the annual calls that have come out, again, that same spike from in 2021 was just the most rough year across the board. When we look at all of our formal statistics, we've, like I said, dropped a little bit, but we are absolutely not out of the woods, and we've never gotten back to those pre-pandemic status when it comes to overdose calls that are coming in through HFD. What are some other things we know that we don't need to rely on formal stats for, right? Active use, it's going to continue until treatment begins. The risk of overdose for anyone who's in active use will continue as long as active use is occurring. And the biggest takeaway is that treatment must meet people where they are at, and we should not be expecting people to have to jump through a lot of hoops or to be in a certain space or to find us, honestly, when it comes time. Like, we want to make sure that we're reaching out and connecting to people who are at risk and who need access and maybe just don't know where to go or what to do. And so they're not being active in stepping into recovery because they feel like they don't have any option for it. And that's where some of those strategies will come into play. What else do we know in our landscape, right? Access to care is problematic. It's rough out there. There's not enough treatment providers. There's not enough funded treatment. And expanding treatment capacity, it's needed, right? But it's not sufficient. Like, we can't just expand everything we're doing. We also have to make sure that we're coordinating better, that we're creating better types of treatment programming, that we're operating on best practices and things of this nature. And the biggest thing is we still live in this like siloed, medical does what they do with their population, criminal justice does what they do with their population, public health does what they do, first responders does what they do. And the reality is all of those populations are the same population. And yet we're kind of putting a band-aid on it from each angle instead of collectively kind of coming together and being like, all right, like, your patient is my patient, your client is my client. Like, let's do a little more of that type of collaborating and coordinating to get us all on the same page. And prior to 2017, which is where the UT Health Heroes came into play, there was really no integrated community capacity happening in the Houston landscape. It was much more siloed than it is now. And we've been able to break down some of those barriers and get more of the stakeholders and the people talking to each other. And I think that's really crucial when we talk about strategies and systems of care, right? And I like this slide because it's just something I want to kind of put out there, plant that little seed, think about it, right? But from the outside, right, especially if you're not in an addiction field, if you're not in a realm where you like understand what's going on here, from the outside, addiction looks very different. It looks reckless, careless, thoughtless, because you're seeing the behaviors of someone who's struggling with active use. And to a certain extent, somewhat it is, right? Like, it is reckless, careless, and thoughtless, but like, that's the disease of addiction. And that's the stuff that if we take a moment to really understand what's driving, right? What happened to you? Like, we can figure out why someone is behaving recklessly, carelessly, thoughtlessly, and what's really going on there. But we also know that it's widely accepted in the medical community that addiction is a disease process, and that it's not, once they've reached that point of being someone who has the disease of addiction, and it's not casual use, it's not controlled use, it's not anything, like, when it meets that criteria of clinical, criteria of substance use disorder, when they're no longer managing their lives because it's taken over, all those types of things, like, we understand that it's a disease and that now they're, someone who needs medical treatment. But if we're in this field, if not to understand and help fight against disease and injury, like, well, what are we doing in this field? So kind of keeping that in mind, like, and I say that because, we work in healthcare, we work in all these other realms, like, we still interact with people sometimes who are like, this isn't my problem and I don't need to deal with this. And that's on them. Like, they created this problem. Like, that's not up to me to resolve. And the reality is if we're in a public health related field, it is up to us, and we should want to get into this space and to help people and to help others. And if not, then maybe looking at like what career choices you're making, of like, maybe this isn't for you, because addiction, again, crosses all those boundaries and needs all of us to help in order to be effective. And if that's not what you're trying to do here, then maybe this isn't a field that is a good match, because it is messy. And we do deal with people who are maybe, in the heat of addiction, appearing reckless, careless, and thoughtless, and they have a disease and they need to be treated like a person. They need to be treated with medical models. All those types of things are really what it is that we are doing. And so kind of keeping that in mind. I also kind of throw out that caveat of, I get we all have tough jobs. Sometimes we're all overworked, underpaid. We aren't trained in everything that we could possibly know, especially with addiction, and even in the healthcare field, right? The fundamentals of addiction are often not a part, or if they are a part, they're a very small part of formal training programs. And so it's hard for everyone to know everything, but we know that lack of education becomes a catalyst for stigma. And so trying to find multidisciplinary collaboration is crucial, trying to educate, trying to call out stigma when we see it, and redirect things that are no longer being helpful. These are the types of things that are really important for strategies to work on this field and in this realm of people struggling with addiction. And so when I say systems of care, I mean all of these, right? Like emergency departments and hospitals, primary care and physicians, first responders, law enforcement, fire EMS, pharmacies. That's a link in the chain we often forget about. Mental health, behavioral health, outpatient substance use, inpatient residential substance use, recovery residences, sober living, justice involved. All of these settings are very, very relevant to the population that we're working with. And we need to make sure that we're not all just doing kind of our job and forgetting that we're interconnected and all of these other things. And working in this space, I will say, right, like we have some great emergency departments. We have some great local partnerships with first responders and law enforcement and fire EMS. And we have some just, great collaborations that are going on. And then I can also list in all of these categories areas where we've struggled because it's not a universal, that one hospital is rocking and rolling with trying to help people struggling with opioid use disorder and the one next door isn't, or you get one first responder that's compassionate and understanding and has some addiction training and background, and then you get another one who may engage in stigmatizing behavior when they come to the same call at the same house for the same reasons over and over and over. They get frustrated with that. Pharmacies are a huge problem in general. And again, it's not to say that there's not some great pharmacies and pharmacists out there, but it's also a big link in the chain where people struggle and they're not able to get connected to medications for their disease and for their long-term management of their disease. And it's very frustrating because by that point, somebody has already gotten through a ton of hurdles. They've accepted that something's not working. They've reached out and asked for help. They've found someone who will help them that they can afford or they're eligible for treatment. They've likely found a doctor who is willing to prescribe for a diagnosable condition, a medical-based treatment modality. And then that script gets sent to a pharmacy. And then the pharmacy's the brick wall that's like, nope, yeah, we're not going to fill it, or they've got all these reasons and excuses. And so at that point, it's like, it doesn't matter how far we came through that chain of care, like we still hit a wall. And now that patient is going to pay a price for that, right? And so keeping in mind all of these systems are equally important. And if we're missing any one chain, any one link in this chain, then it all falls apart and we're not able to do the things that we should be doing when it comes to strategies to treat and support patients in this realm. Just for any medical providers that might be on the call, if you haven't heard, they finally have relaxed and gotten rid of the waiver that's necessary for prescribing Schedule 3 controlled substances. So in this case, buprenorphine, which a lot of people know by brand name Suboxone or Subutex. It used to be highly regulated and hard to access. The waiver is gone. Any prescriber has a DEA waiver to prescribe any other controlled substances, such as other opioids. They can now prescribe medications for OUD. They can prescribe buprenorphine to people. And if you're not comfortable as being a provider who's now like, well, yeah, I know I can prescribe it, but I don't feel comfortable because it's not my realm. Like that's where we want to make sure you're aware there's resources, there's trainings, there's state support, there's, lots of opportunities to help eliminate some of that unfamiliarity and uncomfortableness so that we can, have providers that are part of the solution as well. So if this is news to you, look up the MAID Act, try and get a little more information because I think there's a lot still, despite the waiver disappearing, there's still not a lot of prescribers that are willing to step into this space, even though now it falls very much under their general scope of prescribing as a medical provider. For anyone that's going and working with patients who may be going to OTPs, which are opioid treatment programs, we actually call them NTCs in Texas because we like to be different, narcotic treatment centers. But they've also relaxed and changed some of those rules, changing some of the eligibility, making take homes a little more accessible, allowing, you know, other providers to do the ordering for medications for OUD in these settings, and allowing some telehealth options. So this is happening live. It was recently published. It's effective next month with a hard compliance date of the fall. And last I've seen is, you know, Texas is concurring with these changes, which means that we will have the ability to see some of these relaxed guidelines to increase care and access to care in these settings to be maybe a little more accessible to patients who are trying to figure out how to be, you know, medically managed and in recovery for their opioid use disorder. So I learned something neat in this realm, and I just wanted to mention it. I learned about NNTs, which are number needed to treat. And when it comes to any type of treatment for any type of disease that's out there, there's kind of some algorithms of like, if I treat so many patients for this condition, how many do I need to treat to basically prevent something negative from happening? Or another way to look at it, to get at least one extra positive outcome, right? And so what's really interesting is there's a lot of diseases where the NNT is like in the hundreds when it comes to like blood pressure meds and asthma management and some of these other things. Like the NNT is like, well, we need to treat, you know, 152 people or 382 people to prevent that one outcome of negative and make it a positive outcome instead. And what's really interesting is when we talk about medication maintenance for opioid use disorder, the NNT has a really low number, which means that if I'm prescribing a medication-based treatment for someone with opioid use disorder, like depending on how much I'm prescribing. So if I'm prescribing a low dose, which is not recommended, I have to treat 4 patients to get that positive one outcome in a patient. If I'm prescribing a medium dose of bupe, I only have to treat 3 patients to have at least 1 patient benefit from my treatment. And then for high dose bupe, which is where it's actually recommended for prescribing, I only have to treat 2 to get 1 positive and to prevent that 1 negative from happening. And so it's really neat to see that, you know, really an NNT in single digits is fantastic. Well, you don't see it a lot in medicine, and yet we're very resistant to prescribe medications for someone with OUD, or if we do it at a low dose, or we don't do a good length of time. We don't acknowledge some of the benefits that come along with long-term medication-based treatment. And yet we'll have an NNT in the 300s for blood pressure meds, and we treat patients like that all the time, and they all get scripts and they all have other things going on, even though we're not getting that same benefit back. And so I just thought it was something kind of neat to throw in here, that number needed to treat. We actually have really good outcomes if we treat it in the way that we're supposed to treat it with medication-based models. And it's stigma, right? It's stigma that prevents us from embracing the fact that like the numbers show that if we can roll out and create access and treat it in the way that it's medically recommended to be treated, we actually get good outcomes. It's just there's that barrier of getting people connected and into care, and people who sign on to understand that medication and, you know, a medical model for treatment is what's most effective. And that's where our roles come in, to advocate and to challenge stigma, right? You guys will get a copy of this. I know there's a lot on here, but these are some things that come up a lot. So I just wanted to throw it in there when it comes to what it means to be taking a drug and being in active use with addiction, right? And what it means to be on medication and under the care of a doctor and taking things as prescribed. And I'm not going to go through all of these, but because you will be getting a copy of the slides, right? But this idea of, you know, the mindset of active use versus a mindset of medication, the chasing the high of a drug versus a medication that creates stability and healing in the brain. You know, these types of things are very important. And I think this is one of my favorite go-to charts. I actually have one kind of printed as a handout because it comes up a lot with people who are resistant to medication for OUD. And it's not just replacing one drug with another. And there's a lot of education around that still needs to happen. Treatment needs to be comprehensive, cover all the bases, right? And with that, and looking at the time, I want to jump into what we're doing over at UT Health Heroes. So we are a little bit of everything over here. We are under that UT Health umbrella, right? So we're academic based, we're research based, we're doing a lot of things. We're working in emergency medicine and public health. We've got community-based strategies, behavioral and mental health strategies, informatics, right? Data, backend, everything we do is tracked, and then outcomes research. And so we're trying to kind of come at it from all angles to really understand what's going on. So we're interdisciplinary, kind of working, like I said, with a couple of different hats. We are targeting underserved and vulnerable populations. We are collaborating very closely with a lot of providers in our landscape, and that's been really crucial to the success that we've seen. We're trying to do some things a little different now. Some things are starting to be a little more the norm out there, but when we entered the landscape in 2017, it was very innovative because there wasn't anyone doing that. And we've been a part of kind of helping to change the landscape with the work that we're doing. So we have the Heroes program, which is we're trying to outreach to the people who are highest risk, who are most likely still in active use, using drugs, and get them plugged into care. We have Project Icon, which is looking at kind of more broadly rural communities, a few targeted areas across Texas that we keep adding to help them create their own systems of care, especially in rural areas where they might not have a lot to work with. Getting all the right players involved is crucially important. We were part of a 5-year grant with NIH through the Department of Internal Medicine that was doing some mobile-based healthcare, which is at the sunset. It's starting to wrap up, and we're real excited to see what some of the data from that is. And trying to get into more the biology base of things and some gene-based things to understand things better. So we're kind of a mix of clinical operations, research, and then teaching. We work a lot with students. We work a lot with other schools and education and things like that. We're providing direct patient care, and then everything we do is both research driven and then us producing research to try and help others be in that same realm of things. Anyone can refer to us, but primarily we kind of have some pathways of the emergency department, EMS with our partnership with HFD, criminal justice, our partnership with the Houston Police Department, but ultimately, yeah, in the community, which could include like our OSAR, the council. It could include other providers, maybe residential that are looking for an outpatient option, but self-referral too. Anyone can pick up the phone and call us, and we're going to figure out what we can do, whether it's us getting into that space with you or getting you plugged into someone that might be a better fit for what your needs are. We don't say no to anyone. And if anyone hits a wall, we say, call us back, and we'll get into plan B or plan C, whatever we need to do to get you connected and take the unknowns out of it. And I always say, like, I'm a sober professional, and I struggle with our landscape. I struggle with knowing where people can go and who's eligible for services where, and how do you connect, and no one picks up the phone, and you've got all these barriers, right? And like, imagine if I was in active use and I was living on the streets and I don't have people in my corner to help figure it out. Like, they're not going to be able to navigate that system. Our system is very difficult. And so we try and do a lot of that heavy lifting to take some of that unknown out, to understand the landscape, to be able to create access for people, whether it's with us or with others, and to make sure no one has to go through that process alone. What's really cool about what we do, most of you are in this field are probably familiar with the stages of change. I know this comes up with a lot of things. This idea of kind of, pre-contemplation, contemplation, preparation, action, maintenance. And I like this one because it kind of shows that generally each circle is its own silo, right? There's organizations that exist in the pre-recovery engagement or prevention things. There's the initiation of recovery or stepping into recovery. And then there's like long-term recovery and things like that. And so usually it's kind of a handoff, right? Every circle, I do my part and then I hand off the patient. I do my part and I hand off the patient. What we've done as Heroes is we're kind of all these parts. We're from day 0 when someone may still be struggling in inactive use to day question mark. As long as we keep getting funded and are researching and collecting data and doing all the things that we do, we don't have an end date for our patients. So we get to exist And our role changes, right? Depending on where that individual is in their process. You know, it's not the same as someone in long-term recovery as it is who someone is still actively using. But once a hero, always a hero is kind of our mindset. So we're going to get in that space with you, and then you're stuck with us. Like whatever you got going on, wherever you're at in this process, we're going to get in there and work on it together with you. Generally, our model is, again, kind of figuring out, does somebody meet that criteria with opioid use? And if so, let's have a conversation about medication-based care. Being able to get access to buprenorphine quickly is very important for what we're doing. There's no wait lists, you know, generally in 24 to 48 hours, we're getting them plugged in and connected if they're in this high-risk category of active use. If we're not able to get them in right away, our partnerships with the emergency department, so like weekends and holidays and things where we're not in office, we still have a direct route to get people connected to buprenorphine bridges. And then the goal is to keep them on medication. The research supports 6 months to a year at a minimum for medication-based care. So whether they stick with us or whether we plug them into another provider, kind of depends on their individual circumstances. And then comprehensively, right? Individual counseling, peer recovery coaching, group work, individual work, all this stuff kind of comes together, and we have that rinse and repeat of making sure that people have all of their needs met. And so we're also working in a space where we're helping them find recovery residents if they need a safe and sober place to live. We're supporting them if they're court involved. We're navigating them to other resources that may be relevant for stuff that they need. And so we play a role in, you know, providing direct services for substance use, but then collaborating and referring and connecting with all of our partners to make sure that their other needs get met as well, because you can't treat one and not treat all the other problems and expect things to get better. My standard slide of naloxone. I would hope by this point everyone is familiar with naloxone. I know Narcan's still the big brand name. There are others out there. There's other formulations of different dosages that are out there. But if you don't have access to it and you need access, please reach out to the Heroes program. Let us know, and we can collaborate and coordinate and make sure to get this into the hands of people. I tell people it doesn't save lives sitting in a box in my office at work. Like, it needs to be pushed out to the community. It needs to be pushed out to high-risk individuals and people who may not know if they'll ever come across it, right? Like, even if you don't have addiction in your family or you don't know anyone close to you that's struggling, we have story after story of people who had this on them and were able to save a life in a very unexpected way that they would have never thought. And we're very grateful that they were able to have access to something like this to save a life and to help someone who didn't have access to it. So if you need it, please let us know, and we'll create a plan. We actually pushed out last year a naloxone vending machine, and vending machine, the loose term that the field is using now. It doesn't cost any money. It's free. Our current one is in a UT Health professional building that has public access that people are coming and going through. And so we have the ability for people to access it and grab it on their own. And like I said, save it for a rainy day, because you just never know when you're going to be able to save a life. Real briefly, so we leave a couple minutes for questions if there are any. We also have a Young Heroes program, so ages 13 to 17, people are struggling with substance use, to send them our way. If they're 16 or 17, they are FDA approved for medication-based treatment. If they're younger than 16, then we have, you know, our nurse practitioner assessing them. We have individual counseling available to them, and we'll create a plan with anyone that needs a plan. There's also a Heroes helpline that we run. If you're any of these categories across the state and across anywhere, you're at a higher risk of struggling with substance use and mental health yourselves because of the nature of the work that you do and the things that you've got going on, and maybe more fears about reaching out for help because you don't want your job to know, you don't want your boss to know, you don't want to lose benefits, you don't want to lose your license, you know, anything that's got you worried. We are a confidential line. Give us a call. And we have a lot of resources to support and navigate people to whatever it is that they're possibly looking for, because you can't help others if you're struggling, and we want to support all of the people in these roles as well. We have education available, lots of stuff on site, always adding more modules. These are free. You get a certificate at the end. And so there's a lot to look on there. So the website's on this slide, go check it out. And if you're looking for extra knowledge on certain areas, we've got some good ones in there. And then just our dashboard of some of the things that we do. We're educating a lot of people. We're handling helpline calls. We're distributing naloxone. We're enrolling into our Heroes program. Home visits are from our outreach. We work with HFD. We have an outreach team. If you've overdosed and were naloxoned, then you're on a list, and my paramedic and peer recovery coach are going to come give you a visit and see if they can help you and say, hey, there's help. It's free and it's available. Like, let's figure it out together, right? We're in the research space, we're publishing, but ultimately almost 30,000 encounters in some capacity with all of the work that we're doing. So we try and be very active in our space. And this is my favorite slide to end on, because we don't do it alone. We absolutely do not do it alone. We have some incredible, amazing partners, and we all work together to figure out how to be more effective in this space and to connect some of these dots and to work, smarter, not harder, when it comes to systems of care. And that's me. And that should leave about a couple of minutes if there are any live questions.
Yeah, thank you, Dr.
Okay.
Yatsko. A couple of questions. One is, can you talk a little bit more about the barriers that people are running into in the pharmacies? Are those policy issues? Are those personal? What are they running into?
Maybe you can invite me back for an hour-long session, because that one is so frustrating. I feel like it's a mix of everything. Some pharmacies don't stock buprenorphine, some stock it, but they have all these kind of arbitrary ways of why they would dispense it. They have things where some have decided, like, you're not in the same zip code as us, so we don't want to fill that script. Or if you're not writing a script for at least a full box, we're not opening a new box to fill it. I go on. I've got slides on other things of like pharmacy stigma is real. And, even some really harsh stuff of like, we don't want to deal with those people and things like
Right.
that we've heard. And it's really frustrating. And so
Does that
there's
vary
a
across
lot.
states or across companies or?
Unfortunately, it's pretty universal. I've yet to meet a
Okay.
state where all the pharmacies have got it together. Some are doing a little better than others with accessibility. Texas is struggling, even like the Harris County area. I think it's only 40% of our pharmacies stock buprenorphine. And that may or may not mean they're willing to fill a script with it, but less than half even have it available as an option. Like, we're really struggling in the pharmacy realm. And so, like I said, I know we're short on time, but there's so much in that realm that it's important to find your partners. And, we work very closely with Walgreens and trying to make sure that we identify those types of barriers. We have some of our safety ones that we know are go-to, that they're going to treat our patients well. They have buprenorphine. It's not going to be a struggle because we've worked with them. Like, there's a lot to be done in the pharmacy continuum of care, unfortunately.
All right, very interesting. Second question, with your opiate use disorder clients that you're dealing with, what would you say the percentage is of polysubstance use there? Is that fairly common, or are these people fairly specific with opiates?
It varies. The majority of ours are opiates, but we still have a sizable amount of polysubstance use. The Texas landscape in general has some very interesting data. Meth is in a lot of things. And then even people who think they're taking like Xanax are actually taking fentanyl. It's kind of messy out there. So even if they think they're taking one thing, a lot of times they're not taking what they think they're taking. The good news is when you treat the opioids, sometimes the others get better too. And so it kind of depends. We tackle them individually. We start with the opioid use and then we kind of work our way down. But there's some light research out there to suggest, even if you're on a medication-based regimen for opioids, even though it doesn't directly help with other substance use, like indirectly, you see a lot of patients report that they just feel a little more stable and consistent and healthy, and then the other stuff just isn't needed as much either. There's not as much cravings that come out. for other things, but we tackle it kind of individually and figure out what they got going on. We get the biggest fish first, right? And then we kind of work our way down to see what else is maybe getting in the way and pick our battles with that too.
Great. Well, thank you. Thank you for spending some time with us today and all this fantastic information about what you're doing here in the city and beyond. And if you have any questions, I'm sure Dr. Yatska would be excited to have you contact her at her email there. So thank you all for being with us today. And please join us in the future for more Hope and Healing Center programs.